Good morning, everyone. Welcome to TeleShadowing. We are live on YouTube. Please feel free to ask questions in the chat box as we go along and they will be addressed. I'm honored to introduce our mentor for today, Dr. Viqar. Dr. Viqar completed her internal medicine residency from St. John Medical Center in Detroit, Michigan. She then went on to complete her cardiology fellowship from Michigan State University and a cardiac electrophysiology fellowship from Mayo Clinic in Rochester, Minnesota. She currently serves as the medical director of the cardiac electrophysiology lab at Dallas Regional Med Center and the consultant cardiac electrophysiologist at Dallas Med Physician Group. And now it is my honor to request Dr. Viqar to begin today's session. Thank you.
Thank you so much, everyone, for having me. Thank you, Manal. Thank you for the opportunity. I'm very excited to talk to all of you, let you know about me a little, and then just go over some basic ECGs and some electrical stuff pertaining to the heart. Shall we start? Can you see my screen?
Yes, we can see your screen.
Okay. So let's talk about first, what does this full word cardiac electrophysiologist means? So while a cardiologist means a heart doctor, they're equipped to deal with most cardiovascular conditions, but sometimes managing heart rhythm disorders becomes very complex. If you have electrical arrhythmias, faster heart rate, very slow heart rate, or some other stuff pertaining to the heart involving electricity of the heart, then specialists like me, cardiac electrophysiologists, come into play. They first have to become a cardiologist, and then they can focus on extra training for rhythm disorders of the heart. They can perform radiofrequency or cryoablations, and then implant cardiac implantable electronic devices such as loop recorders for surveillance, pacemakers for pacings, or implantable cardioverter defibrillators. Just like an external defibrillator you see to shock people from arrhythmias, there are implantable cardioverter defibrillators which are implanted inside the body, and the leads go into the heart. So what's the path to become EP? Of course, you have to graduate from med school, become a doctor. You need 3-year residency in internal medicine, then become certified by American Board of Internal Medicine for your internal medicine training. Cardiology research here is optional, but research does help getting into a good training program. 3 years additional training to become a cardiovascular disease specialist cardiologist, and then do the board certification exam by ABIM. And then two additional years to become a cardiac electrophysiologist. And then you have to take your ABIM cardiac electrophysiology certification boards. So this takes some, how many years? 2, 3. So 8 years minimum. And then if you were to do a research year, then that's gonna take another 1 or 2 years after med school. But honestly, it's a very exciting journey, and time passes quickly. It seems like a long journey, but the training and then the learning is so exciting and intense that it's worth this time for training. So my training path, as Manal said, I graduated from King Edward Medical University, did my residency from St. John Medical Center, did my cardiology fellowship at Michigan State, and I trained at Mayo Clinic for cardiac electrophysiology, and I did a year of research training at Mayo Clinic in addition. So let's talk about cardiac conduction. So how does this conduction appear on the ECG? You see those ECGs, squigglies, P wave, QRS. So let's just briefly go over how does it work. So cardiac conduction results in the mechanical beating of the heart. More specifically, the electrical impulses move throughout the conduction system and then results in the mechanical contraction of the heart muscle. So this slide just shows how does the cardiac conduction cycle initiates. So if you look at my screen, can you see my cursor?
Yes.
Yes. So see here, this yellow dot, this is the sinus node. It is placed by nature in the right atrium, in the posterior part of the right atrium, and it's a bit epicardial type of structure. And the cardiac cycle begins with initiation of an electrical impulse that starts in the sinus node or sinoatrial node. This is how it starts, and this is the start of the electrical activity, which is going to propagate into the whole heart in 1 second, as we elucidate in the next slides. So on the right side, you see a typical ECG, P wave, QRS, and T wave, which we all are aware. So it shows that after the SNO fires, the resulting depolarization wave, electrical current wave, passes through the right and left atrium. It stimulates the atrial contraction and produces the P wave on the surface ECG. So see this grayed out zone, this is P wave. And when the sinus node fires, the electricity spreads out into right and left atrium and then results in mechanical contraction of the atria, causing this P wave. So just keep an eye on this gray slide bar as we go over the slides. It's just going to move and then you'll get an idea. So from this, the next it's going to go into the ventricles. But before it goes and attacks the ventricles, this electrical impulse, see how this impulse passes through the bundle of His, which is at the junction of atrium and ventricle. There's an AV node structure. It proceeds through the left and right bundle slowly. But you see after P wave, there's a isoelectrical flat line. So it means there's a delay in the impulse going from the A to V. So this constitutes your PR interval on the EKGs usually. So you have AV node and you have bundle of His, and then you have this special electrical system where it goes to the right bundle and the left bundle of your right and left ventricle, as the name implies. So after leaving the bundles, the impulse goes to the Purkinje fibers. Purkinje fibers are special electrical fibers. They're interlaced all over the right and left ventricles. They're modified cardiac conduction system, which goes and penetrates into the ventricular myocardium. On the ECG, this would represent as your QRS complex in a second, but just pay attention to that gray line. That is the start of the impulse. The Purkinje fibers have very fast velocity. So the impulse goes from P wave to the bundle of His. There's a delay, there's a flat line, but then once it hits the Purkinje system, it rapidly spreads into the both ventricular Purkinje systems. And after that, after the Purkinje system, it goes into the ventricular myocardium. It passes quickly through the Purkinje system and then leads to the depolarization and eventually the mechanical contraction of the ventricles. And then the result is a QRS complex on the EKG. So the Q, and we're going to talk about how does the Q and R and S results in a second. After that, you see again, there's an isoelectric period. This depicts a plateau phase which lasts several hundred milliseconds. Not 100 seconds, milliseconds, just let's pay attention to that. And then again, the grayed out zone is the T wave. This is the repolarization of the ventricle. Anything which is going to depolarize will eventually repolarize. This is the repolarization of the ventricles, generates a current in the body and produces the T wave on the surface electrocardiogram. This takes place slowly and then generates a wider wave. See, when the Purkinje system was moving fast, you had a spiky QRS. And now the repolarization is slow. So see how there's a hump and there's a wide wave. So anything which is wider, it just tells the electrical impulse or the electricity is going to travel slowly. And when you see sharp and spiky stuff, it means the electricity is moving faster through the myocardium. So let's look at some ECG interpretation examples and go over this process just in a little detail. You know, repetition is the key to learn anything. So I will be repeating some of the stuff which we just taught. So for ECG interpretation, let's label those the P, the QRS, and the T wave. The P, as I said, P wave occurs because of the atrial depolarization. The sinus node starts an electrical impulse, and then it results in the atrial contractility and causes a P wave. The QRS complex represents the ventricular depolarization. There's a negative deflection before the R wave. R is the tall wave. And then the next negative deflection after the R wave is a small S wave. And then T wave is the ventricular repolarization. And again, it could be positive, biphasic, or negative. And that would be in a little detail, but depends what lead are you looking at. And if there's a cardiac abnormality, it could be biphasic, it could be negative, or it could be positive. If your electrolytes are off, your repolarization can look different. You can have a bifid T wave, or you can just have a prolonged T wave. So let's look at if you have noticed if you ever get a chance to look at the 12-lead ECG paper, you will see many little squares on it. And then one teeny square is 40 milliseconds in time. And then this little one. And then one box on ECG reading paper is 200 milliseconds. Why? Because each box has 5 small blocks. So 40 times 5 is 200 milliseconds. It's simple math. And how do you convert the rate of the ECG? If you look at ECG, these days modern computers will calculate the heart rate. But I think when you learn as a student or as a doctor, I think it's a good idea, because computers could be wrong sometimes. It's a good idea to learn how to calculate the heart rate on the ECG. There's this very simple formula. If you think 1 minute is 60,000 milliseconds, which is the simple math we all know, then just by looking at 200 milliseconds of each little square, you can just do the math, and then 60,000 milliseconds divided by 600 milliseconds would be 100 beats per minute. So an ECG, we usually look at the heart rate is 70 beats per minute or 60 beats per minute, but we're just going to talk in detail during this talk that the pacemakers and implantable cardioverter defibrillators, those machines, they have highly intricate computer systems in it, and then they calculate intervals in milliseconds, not in rates like beats per minute. So that's why this becomes important, that why do we look at milliseconds on the little ECG paper? But for starters, it's okay to just look at heart rate in general till the cardiologist level, to calculate heart rate in beats per minute. For me, as a cardiac electrophysiologist, sometimes when the arrhythmia is very fast, if I'm talking to another electrophysiologist or talking to a team member in EP, we would sometimes refer to the heart rate in milliseconds when you look at the tachycardia cycle length, like 400 milliseconds or 500 milliseconds, stuff like that. 600 milliseconds is 100 beats per minute. 500 milliseconds would be 120 beats per minute, and then 400 milliseconds is usually 150 beats per minute. So let's look at this complex PQRS. The intervals are important factors when determining whether or not a rhythm is healthy or not. So an interval outside the normal duration can be indicator of the heart problems. If the P wave is too long or it's too broad, it means there's a problem. If the P wave is too sharp, that could be a problem. If your PR interval is very short or very long, it denotes electrical system problems. So in order to learn what is not normal, you really have to know what's normal, as we all know. So PR intervals usually is 120 to 200 milliseconds. And how do you calculate from the start of the P to the start of the QRS is your PR interval. The normal PR interval would be 120 to 200 milliseconds. If your PR interval becomes 300 milliseconds, it means it's abnormal. And then again, the QRS duration, mostly it's 80 to 100 milliseconds, but up to 120 milliseconds is acceptable. But if your QRS becomes very wide, like 300 milliseconds, it means either Purkinje system has a problem or ventricular depolarization is very slow, which could be from arrhythmias or heart muscle function problems in the ventricular myocardium or electrical delay in the ventricular myocardium. And again, the T wave, if the T wave is too broad or the repolarization time is too long, if you ever heard the term, some people have long QT syndrome, or one of those people are prone to arrhythmias just because this cardiac interval is abnormal in them. So when you're looking at ECG, or when you get a chance to look at it, you have to calculate the rate of an ECG tracing, determine the regularity of the given ECG, and then analyze the rhythm. So there are a few things which you look at it. Rate, as we talked about, it's not that difficult. You just have to know the normal rate and then see if the rate is too fast or too slow. And then regularity will go in it in 1 second, and then just look at it. And then the rhythm, what is the relationship of the P wave with the QRS? That determines your rhythm. So let's do the easy way of calculating the heart rate. Milliseconds is great, but it's a little cumbersome and it needs a learning curve. But if you have to just look at a strip, most of the ECG paper has a marker on it, and that is a 3-second marker. If you look at it, see these little arrows? Most of the ECG paper, when you look at the ECG strip, just pay attention to that little arrow. That is telling you that there's a 3-second interval. Between each marker, there's a 3-second interval. So if you look at the strip and then you look at, calculate the time, the 3-second and 3-second interval could be 6-second interval. And then you can use the 6-second rule because 1 minute has 60 seconds in it. So you can look at the 6-second tracing and then multiply that with 10. So you count the number of QRSs, like 1, 2, 3, 4, 5, 6, 7 QRSs. And then you look at the 6-second marker and then you calculate as 7 times 10, 70 beats per minute. But then you just have to make sure you have the 6-second interval strip. So this is an easy way to just calculate the rate. So first of all, you have to know the normal rate. The normal heart rate would be between 60 and 100 beats per minute, or sometimes 50 is fine too. But if less than 50 or more than 100 means it's abnormal heart rate. More than anything, any heart rate more than 100 by definition is tachycardia, and heart rate less than 50 or 60 beats per minute by definition is bradycardia. So once you know the normal heart rate range is this, then you can look at the ECG and then know what's a normal heart rate or what's abnormal heart rate. So let's look at the regularity. So after rhythm, you look at the QRS complexes and see if it's regular or not. Regular means the consistency of the RR interval. The QRS complexes are the regular or not. Or you can look at the PP interval as well. But sometimes the P wave has smaller amplitude and the calculation sometimes could be a little cumbersome. So most people for general purposes use QRS regularity. So you can take a pair of calipers or just take a piece of paper, put 2 marks on it, and then just scan any tracing and look at the RR interval regularity. So with normal sinus rhythm, the interval from one QRS to the other QRS should be consistent. And then some people have can exhibit sinus arrhythmia, which means with respiratory variation. Your ECG can be just a teeny bit irregular, 40 to 80 milliseconds here and there. But in general, with regular eye, if you look at it, you would find it normal and regular. If the RR interval is not regular, it means there's an abnormality. So the PR interval in most cases should remain constant. Every P wave should be followed by every QRS, as we looked at the initial slides. Sinus node fires, goes to AV node and His bundle, then travels to Purkinje fibers and then causes a ventricular depolarization. So every PR, so it means PR interval would be consistent in a normal heart rate. In a normal heart beat. But if the PR interval becomes irregular, means if you have more Ps than QRS complexes, or if you have more QRS complexes than Ps, that means this heart rate is not regular. And then RR regularity, the QRS complex of one to the next beat is not regular, then again, that tells there's no regularity in this rhythm. And then you have to look at, as I said, the PR ratio PR interval. If in one beat your PR interval is 150 milliseconds and in the next beat your PR interval becomes 300 milliseconds, it means there's a problem in the conduction system. Every P is not getting to the ventricular, every P is not causing the ventricular depolarization in a regular manner. Either there's a delay or there's a problem at the level of AV node, His bundle, or when it travels into the ventricle, there's a blockage of conduction system. So let's look at this. This would be a typical normal sinus rhythm. And as I said, I go by this. You have to know what is normal in order to learn what is not normal, because your eyes will know if something is not normal only when you know what you have seen as normal. So let's look at this tracing. This is a normal sinus rhythm. You have a P wave Then you have a flat line between P and the QRS complex, and that is your PR interval. And then you have a QRS complex, and then you have a T wave. If you look at this, this is the PR interval is regular, RR interval is also regular, and then the P wave is present before each QRS complex. And so the ratio is 1:1. Every P is followed by a QRS. And then the QRS width is normal and PR interval is normal. As we discussed before, QRS width should be between 80 to 120 milliseconds, and PR interval should range from 120 to 200 milliseconds. These are some of the numbers which you really don't have to put a lot of attention to memorize. As you see more EKGs over time in your career, it just becomes a second nature, and then you can just look at it and realize the intervals are non-normal. So this would be a prototype of a normal sinus rhythm tracing. I would like you to make just an eye memory of this, so you can next time see, when you look at a different tracing which looks different, so you can discern that this is not normal. So this would be a good prototype for normal sinus rhythm. This next tracing shows a sinus bradycardia. It means that the PP regularity seems to be regular, RR regularity seems to be regular. PR interval with each beat has a normal same interval which the preceding beat has it. You have P to QRS ratio as 1:1. It's normal, QRS width is normal. But the only thing which seems or stands out from this is that this is a slow heart rate. It's called sinus bradycardia, that it is sinus, it follows all the rules of regularity and the rhythm, but the rate is slow. And let's contrast to this. You can just look at this. If you calculate these on a rhythm strip or just look at this, this would be around 300, 150, 100, like 67 beats per minute. And here, this is less than 60 beats per minute. So let's contrast this to sinus tachycardia. As I said, by definition, anything which is called tachycardia means the heart rate has to be above 100 beats per minute. So the PP regularity seems to be regular. RR interval is regular in this. Every P is followed by the QRS, which is the basic rules of normal rhythm strip. And the QRS width is also normal. But what's standing out is the rate. The rate is faster than which we would expect it to be normal. So this rate is around 150 or 140 beats per minute on this tracing. And then you can use calipers to measure. And once you know if you have a 6-second rhythm strip, you multiply that with 10, and then you will get your heart rate. So this shows, now we have seen some examples of the normal rhythm. Let's look at what is a sinus pause, or what does a sinus arrest means. The rate will vary. So see how this is not regular. This P and P interval or QRS are regular. However, if you look at the preceding QRS complex, it's way far behind. And it's if you use a caliper to match the QRS complexes, this would stand out to be irregular. And then the RR is irregular. But it's following one rule of the rhythm, a 1:1 association between P and QRS. When the P results, a QRS results, right? PR interval seems to be normal when the PR interval is present, and the QRS width is as well normal. But you see, when there's no P wave, no QRS happens. So it means it's called sinus arrest, that the sinus node did not fire and did not cause an electrical impulse in the atrium, and hence no QRS happened. So this would be an example of sinus pause or sinus arrest. Next, let's talk about atrial tachycardia. So as the name implies, tachycardia means heart rate more than 100 beats per minute, and atrial means that it is originating from atrium. So this tachycardia is originating from atrium, and it's tachycardia because the heart rate is faster. Usually the heart rate would be more than 100 beats per minute, so 100 to 180 beats per minute. It can start as a sudden onset. Some patient is sitting and all of a sudden he starts feeling palpitations. The morphology of the P wave sometimes will differ from the sinus P wave, because this atrial tachycardia, since it's not originating from the sinus node and it's originating from another part of the atrium, the P wave will look different. And then the QRS width will be normal because the ventricle is just following the fast rate of the atrium. So that would be atrial tachycardia. See, it's normal, and then all of a sudden, the heart wants to speed up and races for a few beats. Next, let's look at multifocal atrial tachycardia. As the name implies, tachycardia means more than 100 beats per minute. Atrial means it's coming from the atrium, and multifocal mean that it's coming from different parts of the atrium. So multifocal atrial tachycardia by definition means you should have 3 different P wave morphologies. If you look at this tracing, there's a P wave here and it's broad based. The next P wave is narrow. The third P wave is a little broad. And if you notice, there's a notch in it. And again, the following P wave is narrow again. And then if you look at this, this is a tall notched P wave. So by definition, we have 3 different types of P waves in this tracing. One is this, the second could be this, and the third could be this type or more. So it means the atrium is having different foci, and that's why it's called multifocal, and it's firing differently. But you notice the P to QRS ratio is the same. Every time there's a P wave, a resulting ventricular depolarization or QRS is happening. And again, the QRS width is normal in this. So it would be irregular because P wave is happening on its own time. But if you see a P to P interval is not regular, and that's why it's irregular, it's multifocal, P wave morphology seems different. And since, and by definition, since heart rate is more than 100, it's called tachycardia. Next, I would like you to get introduced to atrial flutter. Atrial flutter is, I would say, one of the most common human heart arrhythmias, actually. Atrial rate would usually be 250 to 350 beats per minute. It's fluttering. The PP regularity would be regular, and it's PP because there's a flutter wave in it. The P wave morphology is pretty peculiar for this type of flutter. It's a sawtooth wave. Like if you look at it, there's a sawtooth pattern. And the P to QRS ratio can varies because since atrial rate is 250 or 350 beats per minute, the ventricle cannot keep up with that fast rate, which is nature's protective mechanism. So you will have P to QRS ratio 2 to 1, that for every 2 flutter waves, you will have 1 ventricular depolarization. PR interval with varies because this is not a sinus node type arrhythmia. The flutter is just fluttering and going around in the right atrium. And the QRS width would be normal because this is atrial arrhythmia, and ventricular depolarization is still going through the Purkinje system, and hence there would be normal ventricular depolarization. If you look at this baseline, is the bottom tracing in this picture. See how there's a sawtooth P wave of the flutter, and how you see 1, 2, 3 flutter waves are followed by 1 QRS. So there's a block, 3 to 1 block means for every 3 flutter waves, 1 QRS is resulting, which is protective because if your heart rate in the upper chamber in the atrium is 250 beats per minute and all those flutter waves are being conducted in the ventricle, then your heart rate would be 250 beats per minute, which is incompatible with life, and people will pass out. So this is nature's protective mechanism of the AV node and bundle of His, not to let very fast heart rhythms go to the bottom chamber of the heart. But atrial flutter is a common arrhythmia. Patients have palpitations, and atrial flutter and atrial fibrillation. Since it's fluttering in the atrium, blood can pool in these upper chambers, and the left atrial appendage can accumulate that pooling of the blood and can make blood clots. And that's why people who have atrial flutter or atrial fibrillation will need anticoagulation medications to thin their blood when they are in those arrhythmias. That is not the topic for today, but just so you get introduced to the idea of how some people have atrial arrhythmias and they use blood thinners like anticoagulants because of those conditions, because the blood just pools in the upper chambers, and pooled blood can form clots. And sometimes with ventricular contractility, that clot can go into the systemic circulation. Next would be atrial fibrillation. So atrial fibrillation is a sister arrhythmia to atrial flutter. If you look at the last picture, see how atrial flutter is an organized rhythm in the right atrium, and then it's going to the left atrium. But in atrial fibrillation, by contrast, you see how there are multiple wavelets and they're all chaotic and then just going around. So these are all electrical impulses traveling just aimlessly in the right and left atrium. So the atrial fibrillation rate will vary with ventricular response, could be fast or slow, means you can have ongoing fast atrial fibrillation and then your ventricular rate could be very slow, like 50 or 40 beats per minute, or it could be very high, 120 or 130 beats per minute or faster, depending on how is your AV node able to conduct some of the chaotic beats down into his Purkinje system. So PP irregularity will be chaotic atrial activity. You can just look here, there's no discernible P wave. As compared to, or as contrast to the flutter, you see how there's a sawtooth P wave pattern. It's missing in the atrial fibrillation because it's not following a special circuit, and they're just moving chaotically everywhere. There's no discernible P wave. The P to QRS ratio is not present because not every P or atrial fibrillation complex will be followed into the ventricular depolarization, because AV node and his bundle will block those chaotic P wave activity going down into the ventricles. There would no official PR interval because there's no organized P present at all. And then the QRS width could be normal most of the time, but you can develop aberrancy or white complexes, which is, how fast Purkinje system electrical activity can go down, and then it can cause aberrancy. That is a bit complex topic, and it would be beyond the scope of today's talk. So for your purposes, I would say with atrial fibrillation, your QRS width should be with the normal limits, as I said, 80 to 120 milliseconds. So junction rhythm will be a rhythm which is originating from the AV node or his junction from this part. The rate would be 40 to 60 beats per minute. Usually it's junctional escape rhythm. It usually occurs in diseased hearts, especially when your sinus node, which we initially talked in the posterior aspect of the right atrium, if that stops to fire and you have sinus arrest for a longer time, nature has this protective mechanism, you can have junctional escape rhythm. The P wave will be variable. It could be non-antigrade or retrograde, because the P wave has to come from the sinus node, and if the sinus node is not functional, the junctional rhythm may not be followed by every P wave. It could be antigrade, retrograde, because it's not, the junctional rhythm is not resulting from that P wave. So P wave could be anywhere and not related to it. And again, the QRS width would be normal. This would be an example of sinus rhythm with PVC. So you can see that there's a PR interval, and you see a chaotic wide complex beat in the rhythm tracing. So it would be the PP regularity would become irregular because the P was supposed to happen somewhere here, but then hence a PVC came and you cannot see a P wave. It could be buried somewhere here, but the PVC, which as the name suggests, premature ventricular contraction, it's not the result of any P wave. It's just a chaotic focus which fired into the ventricle and caused a resulting wide QRS complex. So you can see sinus node fired, it came to AV node and went into the right and left bundle and then his Purkinje system and caused the first two beats for the sinus rhythm. And then the third beat means that this PVC somewhere, the ventricular myocardium or the conduction system in the ventricle just fired chaotically and caused a PVC. The PVC would be wide complex because it's not coming from the his Purkinje system. It's originating from the local myocardium, and hence through the ventricular myocardium, it traverses, and hence it's a wider QRS. By definition, it would be more than 120 milliseconds. So this would be ventricular rhythm, ventricular escape rhythm at usually 20 to 40 beats per minute. It usually occurs in a diseased heart when your junctional rhythm is not, the junctional escape rhythm occurs when there's sinus arrest or a patient has extreme bradycardia. And in order to prevent asystole, nature has this backup system. One of the focus in the ventricle will start firing to cause some ventricular contractility and depolarization, and usually the heart rate would be 20 to 40 beats per minute, and hence it's starting from the ventricle, so that's why it would be wide complex. Ventricular tachycardia. Let's contrast this to the previous examples of atrial tachycardia we talked about. So as the name suggests, tachycardia means the rate has to be more than 100 beats per minute, and it's ventricular because it's originating from the ventricle. It could be right ventricle or it could be a left ventricle. So rate would be usually 100 to 200 beats per minute. It would be dissociated from the atrial rate. Why? Because the ventricle is firing, your sinus node can fire, and sinus P waves can be seen buried here in the QRSs here, but that is not causing any electrical ventricular depolarization in the ventricle, because ventricular tachycardia is faster and it's taking over. So since it's originating from the ventricular myocardium, you will have wide QRS complexes. So this is a picture which shows that typically heartbeat, you know how a sinus node originates the beat from the right upper in the right atrium, in the posterior aspect of the right atrium, travels to the AV node, then goes to the his Purkinje system, and then causes a typical sinus rhythm with P and QRS complexes. Ventricular tachycardia, by contrast, it can start anywhere in the ventricular myocardium. It could be very fast, and the irregular impulse just swirls around and causes these wide chaotic QRS complexes, which are taking over and causing ventricular tachycardia. So sinus beat can come here. It finds the ventricle in the refractory period, and hence you're not having a resulting QRS complex from the sinus node. The ventricular tachycardia is kind of taking over, and that's why you see some embedded P waves here, but the rate is largely driven by the Vt. Here you see all the QRS complexes are looking the same. It's monomorphic Vt, which means all the morphology is same on the QRS complexes from the ventricular tachycardia. It's usually fast, 200 to 300 beats per minute. It's wide QRS because it's starting from the ventricle, and it's usually regular because it's monomorphic. Let's contrast this to the, this is another 12-lead EKG of the monomorphic ventricular tachycardia. See how the QRS complexes in this rhythm strip look the same. So it means morphology is the same. Let's contrast this with the polymorphic Vt, which is called torsades by definition. It's more chaotic than ventricular tachycardia, which is monomorphic. It would be irregular, variable with wide complexes. To see how complex, some complexes are small, some are tall. This usually occurs with electrolyte issues. Patient is very sick, you have long QT syndrome or some of those problems. These are life-threatening arrhythmias. If not treated in a timely manner, you will lose the patient. This is ventricular fibrillation, which is a cardiac arrest rhythm, which is the worst form of this progressing fast monomorphic Vt. Going into ventricular fibrillation. The rate is indeterminate. It could be super fast, and it's too fast that ECG is not even catching this the rate on that. Ventricle is just fibrillating, and contrast this to your atrial fibrillation rhythm, where the P waves were not present, and then there were chaotic activity in the atrium. Ventricular fibrillation is a life-threatening arrhythmia, and then there's chaotic activity in the ventricles. Again, this is just in contrast, the sinus rhythm strip, and I just wanted you to see it again. This is with first degree AV block. So PR interval, every P is followed by the QRS, but if you notice the P2R interval is longer. It's usually the normal PR interval is 120 to 200 milliseconds, and here this seems to be more than 200 milliseconds. So when the PR interval is prolonged, it's still sinus rhythm, but it's first degree AV block. And this could occur if you are taking medications to slow down your heart rate. That can occur, or sometimes with degeneration of the conduction system with aging can cause sinus degree with first degree AV block. Usually no treatment is required for this. This is just a finding, and the doctor has to keep an eye on patient's ECG from time to time to make sure it's not progressing or worsening to a high grade AV block. This would be an example of sinus rhythm with second degree AV block. So there are 3 degrees, first degree, second degree, and third degree AV block. So in this, you can see with second degree AV block, type 1. So second degree AV block has type 1 and type 2 types. So you can notice here on the top screen, top tracing, PR interval is seems to be normal. On the next beat, you see the PR interval has lengthened. And then on the third beat, this P, there's no resulting QRS complex. So there's a dropped beat. And then after that, you see the next beat PR interval picks up as normal. Then the PR lengthens and the third beat is getting dropped. It doesn't necessarily have to be the third beat. It could be sixth beat or fourth beat or third beat, but it's irregular because the QRS complex will be irregular. However, if you notice, the P to P interval will be normal. If you take a caliper and measure this P to this P and this P, they would be all normal. So it means the AV node is not able to conduct one of the sinus node P wave down to the his Purkinje system. And that's why this PR lengthens initially and then not able to conduct any further. So this is second degree AV block. Let's talk about another type of second degree AV block, which is called type 2. The previous one was type 1, Wenckebach or Mobitz 1, where the PR interval lengthens slowly and then drops it. In this second degree AV block type 2, you see the PR interval remains constant and without warning, it drops it. This is more malignant than the first type because this rather gives you some warning that the PR is getting prolonged and it will drop. In the second degree type 2 AV block, usually you don't get warning, PR interval is constant and all of a sudden you will have a drop beat. P waves would be regular, but then R to R would be irregular. The third type of AV block is third degree AV block or complete heart block, as the name suggests. So you have P waves which are regular, but they're not able to conduct down to the QRS or Purkinje system. So there's a complete block present between the atrium and ventricular conduction system. So P to P would be regular, then PR interval will be variable because there's no a formal PR relationship present between the P wave and the QRS. The Ps are going on their own, and then the QRS has its own slow rate. So this is sinus rhythm with bundle branch block. You know how sometimes you see sinus rhythm, but then the QRS is wide and you wonder, is it ventricular rhythm or does not seem to be normal? So what happens in some patients who have diseased conduction system over time, the P wave originated from here, sinus node, went into AV node from the his system, his Purkinje system, and see how this impulse travels into the right bundle, but it cannot go through the left bundle because left bundle is diseased and it's slowed down. So hence the impulse will travel into the right bundle and then will depolarize the right ventricular myocardium and then will do a transmyocardial muscle to muscle conduction to get to the left ventricle. And that's why the his Purkinje system, the bundle system on the left side is slow or blocked. And then it's going to take longer to depolarize the ventricle myocardium on the left ventricle. And that's why your QRS would be wide and it would be more than 120 milliseconds. You can have a right bundle branch block as well. That impulse goes through the left bundle and then depolarizes the right ventricle later. So that would be, again, a bundle branch block where your QRS would be wide. You can have underlying atrial fibrillation with bundle branch block, means the atrium is just having fibrillation. And then as it conducts down, one of the bundles is blocked. So you will have a wide QRS and it would be irregular because of atrial fibrillation. This is an example of atrial fibrillation with slow ventricular rate, but see, notice the QRS is narrow and it's not wide because it does not seem like that there's a bundle branch block. This is an example strip of the complete heart block. Notice here there's a P wave and then there's no resulting QRS. After some time, randomly another QRS happens, and then the T wave, if you notice this T wave looks different than this T wave, it means there's a bifid irregularity present, which means there's a P wave embedded somewhere here in this QRS complex. And again, there's a P wave going here, there's a P wave going here, and this is a complete disconnect of the atrial and ventricular depolarization. P's are going on their own and QRS complex is going on its own. So this would be again a rhythm strip suggesting normal sinus rhythm, P waves and QRS, P waves and QRS, and all intervals seem to be normal. This would be every P is followed by a QRS. However, the abnormality is that the rate is slow. So by definition, this will be bradycardia. This seems to be every P wave has a QRS following it, but you notice the rate is faster. So by definition, this is going to be sinus tachycardia. This would be an example of sinus arrest. The P is followed by QRS, P is followed by QRS, but then no P happens, and that's why no QRS happens hence. So this would be sinus arrest. And then sinus node wakes up and then causes a P wave, and then a QRS happens resultantly. This is again an example of the atrial flutter, which we had just seen. Notice the sawtooth P wave pattern on the underlying flutter in the atrium, and then the QRS is narrow because ventricular myocardium is just getting a signal from the atrium, which is normal depolarization. This would be atrial fibrillation with slow ventricular rate because the ventricle is beating very slow, and then there's no discernible proper P wave here. So by definition, this is atrial fibrillation because it's irregular and no P wave is seen. This would be atrial fibrillation with rapid ventricular rate. You don't see a good discernible P wave. You see some T's and some fibrillation waves, but it's faster and it's irregular. So it would be AFib with RVR. This would be an example of sinus rhythm and with second degree AV block. You see PR interval is normal here, then PR interval lengthens here, and then this P wave is blocked. And by definition, because of the PR prolongation and then blocking, this is the Wenckebach block, type 1 second degree AV block. This would be complete AV block or third degree heart block because there are P waves without any resulting P to QRS, a good tight relationship. QRS is going on its own, P waves are going on their own. And if you notice, there are more P waves than there are QRSs. So 1, 2, 3, 4, there are 4 P waves in this and only two QRS complexes are happening. So there's a complete AV dissociation, and it's by definition complete heart block. This is a monomorphic ventricular tachycardia. Just for the repetition, I had shown you before as well, but if you see this is white QRS complex and the rate is faster and it's monomorphic. This would be an example of ventricular fibrillation. There is no proper ventricular rate which could be discerned on this, and it's just a squiggly EKG, which means this patient is in VFib and they're having active cardiac arrest. This tracing shows that there are some P waves, but the rate is very fast. And by definition, this would be supraventricular tachycardia. So if you compare with this, these two pictures together, you look at the bottom left picture, sinus node causes a P wave, and then the resulting activity goes to the left atrium, right atrium, goes to AV node and causes a QRS. And the sinus node is causing a rate of around 70-80 beats per minute. On the contrast, you look at this picture on the right bottom, supraventricular tachycardia means sinus node is present here. However, there's chaotic activity happening in the atrium, and then it's coming down into the ventricles as narrow complex tachycardia. So this patient has an accessory pathway, means they have another way of going from the atrium to the ventricle through an accessory additional pathway, and which is causing supraventricular tachycardia. This practice rhythm strip shows wide QRS complexes. If you see, there's a spike here, there's sharp pacing spike present before each QRS, which denotes that this patient is getting paced artificially by a pacemaker, because there's electrical impulse happening after this sharp deflection, which is a ventricular pacemaker sharp spike. This example shows there's a P and then there's a QRS, and then there's flat line because there's cessation of P waves, which is not sinus node activity is not coming back, and hence no activity is happening. It's called sinus arrest, and then after some time By definition, since no other P wave is happening, this is complete asystole. There's flat line. And again, we have talked about sinus pause. When the P happens, QRS is happening. When the P happens, QRS is happening. And then there's a flat line, there's sinus arrest, and there's no resulting QRS happening here. Again, this is an example of tachycardia followed by a flat line, which is causing asystole. This would be an example of atrial flutter, typical sawtooth pattern P waves, followed by narrow QRS complexes, which are very, very slow. So it's atrial flutter with slow ventricular response. So we looked into those EKGs, the rate, regularity, and rhythm. So rhythms could be originating from the atrium, or it could be originating from the ventricles. The normal rate has to be between 60 to 100 beats per minute. And then regularity means RR and PP intervals are regular or not. So that tells if there are rhythm issues, there's a rate issue, and then there's a regularity issue. These would be the basic stuff for just glancing an EKG. As you practice more EKGs down in your career, you will come across these examples. These are the most common human arrhythmias. So this takes me into the next introduction to the cardiac implantable electronic devices. As you saw some of the tracings a few seconds before about those flat lines, asystole or slow heart rate sinus bradycardia, or complete AV block or Mobitz 2 type of AV block, and then the ventricular arrhythmias, faster heart rate. So these devices come in handy and are used for the treatment. So we will talk about some of the pacing concepts. So in this chest X-ray, you see this is patient's right clavicular bone, this is patient's left clavicular bone, and then you see an electronic device implanted, and you see those wires are going through the venous system into the right atrium, and then there's another lead going into the right ventricle. So this would be a typical prototype chest X-ray of a patient who has a cardiac device in situ. Now let's watch this quick movie. I hope it runs. This would be your quick introduction to pacemakers. I'm in no way related to the industry or anything, but it's a good video and I think it's worth watching it. It's from Medtronic.
What is a pacemaker and how does it work? When the heart's natural pacemaker is not working properly, the heart may beat too fast, too slow, or irregularly. A doctor may implant a heart rhythm device like a pacemaker to restore the heart's natural rhythm. Traditional pacemakers are implanted in the upper chest, under the skin, just below the collarbone. The battery-powered pacemaker device is traditionally connected to the heart by wires called leads. Micra, the world's smallest pacemaker, is another pacemaker option for some patients who only require pacing in the right ventricle. It is about the size of a vitamin capsule. Micra is small, but it senses and paces just like a traditional pacemaker. Micra is implanted by a minimally invasive procedure directly into the right ventricle of the heart. During the procedure, Micra is placed against the heart wall and secured with flexible tines. This allows Micra to be invisible from the outside and eliminates any leads, chest scar, or pacemaker bump under the skin. Each of these pacemakers can send electrical impulses to help stimulate the heart. To learn more about pacemaker.
So thank you for watching that. So there are two types of pacemakers present these days: traditional pacemakers with leads, and then leadless pacemakers are also present, which go through the femoral venous axis and go into the right ventricular chamber. So pacemakers, the traditional pacemakers could be of 2 or 3 different kinds. Single chamber pacemaker means, as the name says, single chamber. So you insert the lead of the pacemaker into one of the chambers of the heart and connect it to a pacemaker system. The dual chamber pacemaker systems, as the name says, one lead is implanted in the right atrium and the other lead is implanted in the right ventricle. Dual chamber systems are used in cases of AV block, second degree Mobitz 2 AV block, or a complete AV block, or in some patients who have sinus node disease with not reliable AV node conduction. And then this is just a prototype example of how it would show on the chest X-ray. If you look at this model, right atrial lead is placed in the right atrial appendage, and right ventricular lead is placed usually in the right ventricular apical septum. And then this is the tip of the lead on the X-ray, and then this would be the tip of the lead on X-ray in the right atrial appendage, and then this is the pacemaker battery. We see many patients with implanted devices, and sometimes, unfortunately, patients does not know what device do they have. Some can forget because pacemakers last 7 to 10 years, and some of the patients would have forgotten what pacemaker model did they have, or what type of device do they have in the heart. So when you do the chest X-ray, it gives you a lot of information. You can look at how many leads do they have, and sometimes by looking at the shape of the this pacemaker can, you can discern which manufacturer has made that device. Most of the EPs will be able to just look at the X-ray and can tell what type of device is this. Is this a pacemaker, or is this an implantable cardioverter defibrillator, or loop recorder inserted, or it's a traditional pacemaker, or it's a leadless pacemaker. So in this picture above, as you see, there's an atrial lead, and then there's an RV lead present in the body. So looking at X-ray is important sometimes. Or sometimes patient comes and they're intubated, they're unresponsive, and you want to know what type of device do they have. Chest X-ray is handy. The third type of pacemaker, which I would like you to get introduced, would be a triple chamber system, or it's called a CRT system, cardiac resynchronization therapy type systems. So leads will be placed in the right atrium, right ventricle, like a dual chamber traditional pacemaker system, but then the left ventricular lead will be placed in the coronary sinus. You will not place the lead in the left ventricle directly, because there's risk of thrombus if you place something in the arterial system. So these pacemakers are placed in the venous system. So right atrium, right ventricle, and then the coronary sinus will be used since it runs behind the left atrium, those branches, and you can leverage the human anatomy and place the lead in that to resynchronize the heartbeat. This would be an example of the triple chamber or CRT system. See how the coronary sinus can be used. So if you look at this picture, this is a pacemaker can, and then the leads are going through the venous system. This is the axillary subclavian venous system. And then the right atrial lead is placed in the right atrial appendage. RV lead is placed in the right ventricular apical septum. And if you notice here, the third lead comes into the right atrium and then enters the coronary sinus ostium from the right atrium, and then leaves the heart, leaves the endocardial part of the heart, goes epicardially, and then just goes into the coronary sinus, and the lead can be placed in this sinus here. So see here, you go through the right atrium and then go into the coronary sinus and leverage one of the branches and place the lead into the venous system inside the left ventricle. Over the left ventricle, I'm sorry, in the vein. This is how the chest X-ray would look like for the CRT system, right atrial lead, RV lead, and then the coronary sinus lead. What are the components of the pacemaker system? So the pacemaker will have a battery. It will have a circuitry, and it will have connectors to connect those leads into the pacemaker system. And then the leads are wires which go into the heart. And since these are electrical wires which are insulated, there's a cathode and there's an anode system present. These are bipolar leads traditionally these days. So body tissue is part of the circuit in the sense that it transmits the electrical impulses cell to cell as the electrode tissue at the electrode tissue interface. When the lead impedance is measured, it includes the portion of the circuit as well. So you have the pulse generator, the leads, and then the body tissue. So this completes the circuit. The pulse generator is made from the lithium iodine batteries, and then the longevity depends on how much you're using the pacemaker. So 6 to 12 years would be a regular longevity. And then lithium iodine is the most commonly used power source for today's pacemaker generators. Leads are insulated wires that deliver electrical impulses from the pulse generator to the heart, and then they sense the cardiac depolarization. And then the lead tip has The lead insulators are silicone and polyurethane insulated materials are used. And silicone has proven to be a reliable insulating material because the heart usually beats 35 million times a year. So these leads have to really have to go through the wear and tear of the movement stress. These are pretty reliable leads, last many, many years, 30, 40 years or so. As we talked about the pacemaker circuit system, leads, devices, and tissue are needed for that circuitry. So let's quickly talk about the concepts of ICD technology, implantable cardioverter defibrillators. These are the defibrillators which are placed internally inside the body. So let's watch this movie again and again. I'm not related to the industry, but this is a helpful video. That's why I brought it to this lecture.
When the heart's natural pacemaker is not working properly, the heart may beat too fast, too slow, or irregularly. A doctor may implant a heart rhythm device like a pacemaker or defibrillator to restore the heart's natural rhythm. These devices are traditionally implanted in the upper chest beneath the collarbone and are about the size of a stopwatch. These battery-powered devices are connected to the heart with a lead, a thin, flexible wire that is traditionally inserted into a vein, into a heart chamber. An internal defibrillator can sense when the heart is beating too fast, called tachycardia. In this case, the device will send small, painless electrical pulses to correct the heart rate. If the rapid heart rate continues, the defibrillator will deliver a necessary life-saving shock and restore the heart to a more normal rate.
So the implantable cardiac defibrillators have everything which pacemaker will have it for pacing, but it would do another important function of defibrillating the heart from tachycardia. So the life-threatening arrhythms will cause sudden cardiac arrest, and which results in death if not treated. And as you all know, September is the sudden cardiac death awareness month. So we are in September, so I just wanted to mention. 98% of the people will survive a lethal arrhythmia when treated with defibrillation quickly. The purpose of an ICD is to treat abnormal ventricular heart rhythms such as ventricular tachycardia and ventricular fibrillation. In people who are having recurrent rhythm problems, these are the candidates for implantable cardioverter defibrillators. And in some patients who are high risk for ventricular arrhythmias, they will also be candidates to be placed, to have ICDs placed for primary prevention of sudden cardiac death. And as we looked at that movie, which was very helpful, so implanted ICD can is here. The two wires go into the heart. Atrial lead goes into the right atrial chamber in the right atrial appendage, and then the RV lead. This lead is different than the pacemaker lead because this lead has shocking coil present in its body, which delivers the electrical shock in at times when you are in abnormal heart rhythm. The defibrillator will be different than pacemaker in its circuit and battery because it will have the battery just like the pacemaker has it. It will have the circuitry like the pacemaker, but it will have the capacitor and transformer for generating high voltage shocks. The bulk of the device size is due to the capacitor and battery. So the defibrillators are larger in size than the pacemaker cans. And how is the high voltage created? The battery is usually 3.2 volts in the cardiac implantable electronic devices. The energy used for both pacing and defibrillation comes from the same battery. So you have the 3.2 volt battery, but then you have a capacitor which saves the high energy, and then you have the transformer which multiplies this voltage. And you can deliver a shock up to 40 joules or 800 volts from those implantable cardioverter defibrillators because of the transformer and the capacitor function of the battery. The shock is really painful, but it's life-saving. So the leads, as we talked about the pacemaker leads, this lead is a little different. If you pay attention to the tip, this is a bipolar RV tip to RV ring. And then this will be the shock coil because the coils are present to deliver the high voltage impulse to the ventricular myocardium to defibrillate the heart. So the major functions of ICT will be, it would sense the appropriate cardiac signals, just like a pacemaker. It would detect the dangerous rhythms reliably. And then it will provide the defibrillation therapy, which is life-saving. This is just an example of a pacemaker tracing, defibrillator tracing, I'm sorry, where it shows the electrical channels. This is the atrial channel where you see the, this is the surface QRS ECG channel where you see the QRSs. And then later on, this is the atrial channel. This is the ventricular channel where you see VFib or VT happening. And then you see there's an electrical shock of 35.6 joules delivered, restoring sinus rhythm. So these are devices which provide life-saving therapies to the appropriate patients. So this is the life of the electrophysiologist working on those devices, pacemakers, performing ablations and stuff. I will stop here and we can open up for questions. Thank you so much for everyone's time.
Well, thank you so much for your mentorship and teaching, Dr. Viqar. We really appreciate you taking the time. So we're now going to switch on to our Q&A session.
Thank you for your mentorship and teaching, Dr. Viqar. We will now begin our Q&A session. My name is Hamza. I'm a student at Seton Hill University and in the 8-year BSDO program at the Lake Erie College of Osteopathic Medicine. To start off our Q&A, many of our students were curious to learn more about why you decided to pursue EP and why you decided to subspecialize in cardiology.
Yes, congratulations on your educational pathway. Thank you for having me. The decision to become a cardiologist or EP was multi-step. As a student, every rotation I did, I was just, I was impressed by the technology in medicine, and I thought I wanted to be a nephrologist. And then I did another rotation, and I thought, oh, this is who I want to be. But truly, when I started doing my cardiology rotations, I felt we could make a huge difference in patients' life. And then there will be so many things which could have been prevented or could have been treated so well. And I was just amazed and blown away by the technology in cardiology. And then when I did my EP rotations, I looked at some of the things and then the type of difference you could make in patients' life was just mind-blowing. As you know, some of the patients who have supraventricular tachycardias or young patients who are born with accessory pathways, WPW type syndromes, these are highly curable problems with the ablation therapies. So it's not that the patient will keep having the problem and it will keep coming to you. Yes, there are some patients who have chronic conditions, but some of the EP therapies which are available these days are pretty much curative. It would make a huge difference in patients' life. It gives me immense pleasure sometimes telling a young person that, hey, your arrhythmia has been fixed and you can just follow with us every year. You don't have to follow up with us regularly because you're pretty much cured from your problem. And that just is a huge game changer in modern technology and EP. So I'm glad to be part of this technology in this day and age and part of this subspecialty. But I was blessed with very good mentors. That's why, you know how you like certain mentors and you just want to follow them and you want to be like one of them. And I'm very blessed to have those people in my life.
Thank you very much. The next question we have is, what is the best way to memorize abnormal EKGs besides practicing? Do you recommend that students interested in cardiology to study more EKGs?
So honestly, there's no, my mentor used to teach me this thing, you know how people memorize, oh, PR interval, first degree AV block means the PR has to be more than 200 milliseconds. This is how you have to remember. He always discouraged me to memorize the numbers. It is the pattern recognition. Repetition is the key. If you start looking at every patient's EKG and just
It seems that the doctor is experiencing some technical issues. We'll wait a few minutes. Right. Welcome back. You cut out earlier. You're muted right now.
Is this better now?
Yes, it's better.
So yeah, there's no need for a huge memorization. If you can just look at a basic 10 EKGs and then just build your knowledge on that. It's just like if you keep looking at EKGs, if you see 10 patients a day, I would encourage you to look at each patient's ECG and then just look at different things. If someone came with electrolyte imbalances and they have kidney disease, please go look at their ECG. If they had high potassium, look at the ECG, look at the peaked T waves on that patient. If someone has come with non-cardiac problem, it does not mean that if they received an ECG, you don't need to look at it because they came with arm pain. Repetition is the key. If you're genuinely interested, just look at all of them and one day it will just all come to you.
Thank you very much for that answer as well.
As I said, when you look at ECGs, do your homework, study, but ask your teachers, ask your mentors, ask questions, do ECG session with your friends, make a small ECG club, look at them. You will learn them very quickly.
Now, I've worked in the cardiologist's office for a little while, and we did look at EKGs. I'm an undergraduate student, so I don't know them that well. But the nursing student who was also with me, he was able to figure it out to some extent. How long do you think it takes to master looking at EKGs? Because he had already done it for a while, but he's only able to make out a little bit.
As I said, repetition is the key. If you're going to see many ECGs every day, yes, you're going to be good at them sooner versus somebody who sees 10 ECGs a month versus somebody who sees 5 to 7 ECGs per day. It's going to be different, but I would say if you look at them for 6 to 8 months and work on them regularly, go back, study, do pattern recognition, there's not a huge learning curve.
Thank you very much for that answer. The next question we have is, what is the cause of VFib cardiac arrest?
Number one on the top of the list would be ischemia. If somebody's having an active heart attack, the heart muscle is not getting enough blood supply, that could be an arrhythmia they could present with. The other things could be if they have history of heart failure, they have electrolyte imbalances, or they have one of the long QT type syndromes, or they have channelopathies, genetic abnormalities responsible for conduction system disease will get VFib. But the top of the list would be active heart attack, lack of blood supply to the ventricular myocardium will cause ventricular fibrillation.
A follow-up question to that is, what is the prognosis of patients who have been resuscitated from VFib cardiac arrest?
Prognosis is good for the in-hospital cardiac arrest and out-of-hospital cardiac arrest. The sooner they get CPR and defibrillation, patients will make it. Having said that, only 5% of the patients will make it alive. 95% of the patients, unfortunately, will not make it because not very readily availability of the external automatic defibrillators in the communities, or people unaware about the importance of doing good CPR. So those are the factors. But if you can get them sooner, they get defibrillated, they get CPR, the prognosis is good if they make it to the hospital.
Now, I've heard in the past that CPR doesn't always necessarily guarantee that a patient will survive, and that it actually works very little. How true is that myth?
You cannot undermine the value of a good CPR. And good CPR means when you do attend your CPR training class, you will know that the the chest compressions have to be meaningful and good quality compression. Yes, if they have an underlying disease and you're defibrillating time and again, and they're doing CPR, and it depends on the patient condition. Somebody who does not have much in the way of structural heart disease, a good CPR is life-saving. I'm a huge proponent for good CPR. I would disagree with that statement.
Okay. Thank you very much for that answer as well. You mentioned that we place leads in the venous system and not the arterial system because of the risk of clot formation in the arterial system. Is there a risk of clots in the venous system as well, though?
Yes, but you know how your veins drain into your lungs, so you will not make that clot into your arterial system and cause embolization. But yes, there could be clots on the venous side of the veins. Yes. And we hope that, they don't go and cause pulmonary embolism and then don't get stuck in the pulmonary vasculature. But you can sometimes make a clot on any lead. But if you make a clot on the lead and it's in your arterial system by mistake, then that clot will embolize into your arterial system and will cause showering of emboli in your brain, heart, kidneys, or everywhere, and cause strokes.
Thank you very much for that answer as well. Here's a question that a lot of people have asked, even in the chat. How do you manage your work-life balance? Especially as a woman in the field, how many years of intense learning and time? How do you get the balance of getting a high education with a family life during medical school, residency, and fellowships?
Yeah, that's a very difficult question. I think everybody will have a different answer for that. It really depends how passionate are you about something. And I'm a huge proponent of the balance. If you want to do something, it doesn't mean you have to spend 15 hours every day on that. I think family support is important in getting anything done. So yes, life balance becomes difficult at times, but I think just having a good routine, having discipline, and then having a healthy lifestyle and a good mindset helps.
Okay, thank you. And this is for our last question. What is some advice you have for students who are interested in pursuing electrophysiology?
My advice would be do your internal medicine residency, get a feel for it, do some cardiology rotations in your hospital, find a cardiac electrophysiologist who could be your mentor, or meet with some cardiac electrophysiology fellows, do some EP rotations, do some cardiology rotations, work in the arrhythmia or device clinic for your rotation as an outpatient or inpatient, and get a feel for it. And then get exposed to it and see if this is something you really want to do. But anybody who's going to rotate through arrhythmia or device clinic will be blown away by the technology. And I'm sure once you come to the EP rotations, you become a fan of those.
And thank you, Dr. Viqar. These are all of our questions we have for today.
Well, thank you so much for everyone's time. Thank you so much for having me. I enjoyed being here with you guys.
All right. Thank you so much, Dr. Viqar. We really appreciate you taking the time to answer all of our questions so thoroughly and taking the time out of your day to mentor us. I'd love everyone to please give a warm thank you to Dr. Viqar in the chat box for this incredibly informative session. All right, now we're going to conduct our closing session with our quiz and future session dates. So the link to the quiz for this session is now live, and you'll need a 70% or higher to pass and receive certification. That link is in the chat now. Now on to our future session dates. These dates will also be posted throughout our social media outlets, so be sure to follow us at TeleShadowing. I'm looking forward to seeing everyone at our next session next Saturday, September 24 at 10 a.m. Eastern Standard Time with our physician mentoring us in cardiology for our last session of Cardiology Month. Thank you so much to everyone for attending today's session, and I hope to see you in upcoming sessions as well. This concludes this week's shadowing.